Do you always prefer the knee in a flex position?
Yeah, so I started at they say between 30 and 45, I'm in the middle of 45 probably, and it just puts a little bit of tension, and allows you to see it in a bit more detail. So I've got the rectus femoris here, okay, and I'm just gonna pause that a minute, and I'm just gonna annotate. So this is your rectus femoris. This is your vastus intermedius, and we haven't quite got medialis or lateralis on the screen just as yet. So that's just to give you an idea there. Okay. Now, as I start to come down, you'll see that this comes into a tendon here now. Okay. So now I'm on the rec fem tendon, and you can see medialis coming in here. This area here is medialis, and if I go over to this side, this will be lateralis. Okay, so I go back up. I'm on rec fem, and I come down into the tendon of rec fem, and I can follow that. It goes very, very thin now, but you'll notice that the quadriceps all meets together. As we come down, you can see a bit of the trochlea here, and then onto the surface here, which is a little bit difficult to see there. Let's bring that down. That's a bit too much. Okay, so if I go in long section, and I go back up, you'll see I'm in the muscle belly here. There's my arrow. Just going to zoom out a little bit. So I'm back into the muscle belly, and I'm going to follow it down until it meets the tendon. Here's the tendon fiber here. And it comes all the way down to the patella here. Okay, now it does actually go over the top and then continuous with the patella tendon. Patella tendon. So this quad tendon is made up of the rectus femoris, which will be one of the top layers here. And then we've got the vastus intermedius, which will be one of the lower fibers. Okay, and then the medialis and lateralis coming in at the side. So if I show you that, so all these are like conjoined fibers coming in now. A bit of lateralis, which is over here, and medialis, which is here, and they'll all come and join into this tendon as it joins onto the top of the patella there. Now you can get little spurlings here, little osteophytes, and the idea is to you can put the Doppler on, see if there's any hyperemia. But my setting's a little bit too high there, so just bring those down a bit. There you go.
What are you adjusting there, Adrian, for the audience?
Yeah, so I'm adjusting the colour gain, taking it right down, and if that doesn't work, I'm on. Let's just go on to colour for a minute to describe that. So if I turn the colour gain up, you see I get all this artifact. Okay.
So if the gain's too high,
yeah,
you can be seeing stuff that's not actually there.
So you see all that. I don't want that. That's all aliasing. That's all artifacts. So that's got to go. So I've got to basically just take my gain right down until that all goes. Okay, and then I can alter the frequency and the scale, and that would be the sensitivity. That's probably a bit too sensitive. Look, it's still starting to be bright, flare again. So I'll take the sensitivity back up a bit. Okay. So if I go back up, so you can see if I go a little bit further up here and open out a bit, I've got the Intermedius here. So that's just Intermedius. If I bring the focus down, so you can see that. So if I freeze that, we should be able to get Rec Fem, Medialis, lateralis, Intermedius there. Okay. And this is the sort of fascial plane, if you like, and then all these will converge into that tendon, onto the patella tendon. Here it comes.
So you're approximately a third up the way with my thigh.
Yeah, so I'm quite high. You see now it's starting to all form into tendon. Okay. And this is all combination of all the tendon now coming on, and then this is the top of the patella here. I can switch into long section right on the hop there, and there it is there. So if I let your leg go down a little bit, Abid, then you can see here.
So I've just extended my leg about 30 degrees further.
Yeah, so that just opened out this joint a little bit here. So this is the suprapatellar pouch or recess, whatever you want to call it. And this is where you look for effusions here coming up from that. This is the normal amount of fluid here. If it starts extending over the fat pad here, then that would be classed as abnormal. Okay, you've got another fat pad here.
And how do you tell the difference between the tendon and the fat pad? What are the specific features?
Well, if you look at the fat pad, it's all just specularly. Okay, it hasn't really got any sort of pattern to it. It's just a homogeneous echogenicity. It's like a lump of tissue. Whereas the tendon, you can actually see the fibrillar pattern of the tendon here, with the fibres, the way they come down. Okay, and then there's the other fat pad here. So you can see the difference between the tendon here and the fat pads. Yeah.
And if you're struggling to see the difference in the grayscale, how can we alter the image to give us more detail?
Well, you can obviously play with the gain. Now you can use what's called a dynamic range, but I don't know which one it is on here offhand. There's a compound imaging that may give you a little bit of change.
Quite a difference.
Grayscale. Yeah, you can change the chroma maps as well, which I use quite a lot actually, which not many people do, but it's quite good just to have a change in colour, just to see how that changes with your eye. It's usually quite good. That's usually quite a good one to see for sort of medial meniscus and things like that. So you can have a
and what depth are you at here, just to clarify for the audience as well? What's the preferred depth of scanning the anterior?
Here I'm at 2 centimetres depth here. But obviously depending on the size of your knee you've got, we'll determine that.
Would you use any other probe, or are you happy with this?
This probe tends to be the best probe. I mean, if you've got really chunky people with chunky thighs and things like that, you could switch to an abdominal probe, but you'll lose a lot of detail in the image that way. But you probably just go down on the frequency to start with. Take the frequency right down, and it will just penetrate a little bit more. So I'm at 8.5 frequency here, 10, and then up to 17, which is the maximum. Yeah, so that is the quadriceps tendon.
What is the most common pathology you've seen in your experience scanning at knees? What's the most common?
In the anterior knee here, I don't tend to see many ruptures or tendon tears. Obviously, you get the odd trauma come through, and you do see tendon ruptures, things like that. They're quite exciting to look at. But it tends to be around here: osteophytes, calcification within the tendon, effusion out of the joint here. Use my arrow. Yeah, effusion out of the joint here, a bit of synovium, and things like that.
Are there any indications that you see, or referrals for knee scanning that are not appropriate, and you think MRI is the better test? I mean, what can you give people an example of what good scanning referrals are for anterior knee?
I mean, you can, with ultrasound, you can look at things like the PCL and bits of the meniscus, but really they're not. It's not the ideal test. You want MRI for those sort of things. When I look at the medial and lateral knee in a couple of weeks, you'll see that you can see aspects of the meniscus, but you shouldn't really comment on it really, because you can't really look at the whole meniscus with it. You can see aspects of the PCL and ACL even, but again, MRI is the best test for that.
Who tends to refer your knees? Are you getting a lot from GPs or from therapists? Or
GPs, physios, the orthopedics.
What do the orthopedics generally ask for?
Well, they tend to be query rupture or tendinosis or things like that. But I don't get many from orthopedics, to be perfectly honest. They tend to be GPs and physios and things like that. Okay, so we'll just move this up a little bit. So the other thing you can look at is if you bend the knee right up, okay, so you can see how sharp I've got the knee now. You can look at, let's just...
what orientation are you in there, Adrian?
I'm in transverse section, so I'm going across the knee. I just wanted the trapezoid, open that up a bit. So this is the trochlea. You can see this lovely black line here, all this thickness here, that's all cartilage, very healthy cartilage. And you can, if you go out to the side, you can pick up little osteophytes on the edge here. You can pick up gout, you can pick up CPPD. I've got a slide of that later. I'll show you that. And then again, look for little osteophytes around here as well, because you can pick those up. If you've got any fluid in the joint, when you turn to come this way, you'll see it bellowing up here as well.
And can you point out where the suprapatellar pouch and effusions might be? What part of the knee would we see those in? Where should we scan to find?
Yeah, so that's what I was looking at earlier. So this would be suprapatellar pouch here. I'm just going to again. I might just take the frequency down a bit just to penetrate that a bit and add a bit more gel.
Do they tend to be more medial or more lateral?
Well, the thing is, I was going to say, this is such a broad tendon. You scan all the way through the tendon, and as you'll do that, you might pick up fluid that tracks out to the side. I'm pointing at the screen, you're not seeing that here. It tracks out to the side here, and it can be, you'll see a big black load of fluid here, and as you scan across the knee, you'll see a load of fluid, and it will just cover both medial and lateral areas.
Sometimes with synovitis?
Yeah, little synovitis, you'll see little bits of this sort of appearance actually coming up from the joint, and it looks like a seaweed floating in the water. It'll flap around in the water, and you can put the Doppler on to see if there's any active synovitis on there. So that's usually quite good. Don't see that often, to be honest, but you can do that.
We do aspirate knee fusions quite a lot with ultrasound. It's pretty cool to do because you can get really accurately into the pocket, and you can know exactly when you've emptied it out or left a bit behind.
Yeah, nice.
It can be really surprising how much volume some people have in a knee fusion.
Yeah.
Some are just 10 mils, some are 100 mils.
Yeah, yeah. It's such a big pouch. It extends, as I say, across lateral and medial aspects, so you can get a lot of fluid out of there. Yeah, have a look across this is the patella here, have a look across the patella, make sure there's no sort of surface irregularity, little avulsion injuries maybe. So yeah, so that's that. I'm just trying to think of anything before I go a little bit lower.
A little bit.
The other thing is, we'll go over there's a few bursas around the knee. One of them is the prepatellar bursa, which will be here. So this is the patella, and this is the skin going across the patella. Now I don't know whether you can just make that out. I'll make this a bit more obvious now. Hold on. I'm going to use a load of gel for this. Now, can you see that? If I freeze that, this here is gel. And we call that standoff. Okay. Now this is what you want to do when you're looking for prepatellar bursa, because obviously if you don't have that, you'll squash the bursa and you won't see it. So you need to see this gel standoff, and then you'll comfortably see the bursa in here. Because if you don't, like that now, look, I'm literally just resting my probe on top and I've squashed it. Okay, you don't see that standoff anymore. So you need to have a good standoff to see that bursa there.
Adrian, can I ask, do you find the plica easy to image?
Not really. I mean, you will see it, but if you've got a lot of fluid in there, you'll see it, but not really. It doesn't jump out at you unless you've got a lot of fluid in there. But it'd be around there somewhere in here. Let me just go over the top here. So this is the patella tendon. Okay. So this is where you pick up things like jumper's knee. So around here. So usually this can be really thickened. It's looking a little bit dark there. That's probably my angle. If I just angle out here, you see I've cleared that now. That looks nice and bright. And then I can put the power Doppler and see if there's any tendinosis there, and there isn't. That's just our artifact. Okay, again, this is a broad tendon, so you need to scan all the way one side to all the way the other side. Make sure you pick all that up. Okay, and then obviously go in transverse section down, and then if I just freeze that. So all this here is patella tendon. All this here. So it's quite, you can see it's quite a broad tendon. Okay. And you follow that down onto tibial tuberosity. There. And again, if you're scanning any young athletes, young children or anything like that, this is where you pick up osgood slatters, where you get little bony avulsion pull-offs here, and it looks quite irregular. And you can even pick it up in adults actually that have previous osgood slatters, and they've still got the defect there on the bony injury there. You see it. It just happens there.
This would just be an irregular shape to the bone.
Yeah.
Sometimes you get sort of separations, look like big chunks of calcium.
Yeah, that's it. Or this it wouldn't be this smooth. So it'd be regular. There'd be sort of bony fragments coming off, as if like a little avulsion injury. There.
But the tendon appears sonographically normal.
Yes. Yeah. There's other bursas in the knee here. You've got a deep suprapatellar bursa here, and infrapatellar bursa here, superficial, and there's a deep one here. So you're looking for fluid there. Now, when I was talking about earlier about ACL ruptures, I mean, you wouldn't really use ultrasound to look at the ACL, but if they have got an ACL rupture, you can see indirect signs of ACL rupture with just sort of fluid coming up here through this fat pad. This is all fat pad here. And you can see like a pocket of fluid here. So if you see that, you should think maybe just do a test for the ACL, see if that's ruptured. And the other thing is this structure here. I was probably going to put this on the lateral knee, but it does sort of attach onto the anterior aspect. This is the ITB. So this is on Gerdy's tubercle on the tibia, and you can see that this is all this here is the iliotibial band, and that goes up that way, and it will tend to, just as it goes over this condyle here, is where you get that ITB syndrome, and it just look thickened, might be a bit of edema, things like that. And those physios that are on the call will know how to test for that. And if you can obviously scan while you're testing for that, then that's even better. And that goes up and then back down onto Gerdy's tubercle. So just to recap the anterior then, going up to the here, I'll just, what I'm going to do here is put the trapezoid on, which just opens out the image. I don't know if you can see that open out a bit, just gives you a bit more real estate to look at. Okay. So, how's your arm, Abid? You get?
Yeah, I'm just getting a bit of shoulder impingement again, holding this bloody selfie stick, but it's fine.
So you've got Rectum, Intermedius, coming down into the tendon, and then we've got obviously Medialis, lateralis, and then as we come right down, we go straight into the tendon, and that's all. You can probably make out the difference there. Rectum, there's the intermedius down most inferior. See if I can get that. And steam my glasses again. There we go. Hopefully that's a little bit more clearer. Looking at scanning all through the tendon, so all the way across medial, all the way across lateral, make sure you cover the whole tendon, because this part of the tendon could look normal, yet the lateral aspect might look abnormal. So you scan it all the way across, so you get the whole band of that tendon in. Okay. I'll turn the gain up a bit, so it might look a bit bright on your screens, but it might be a bit easier to see. So yeah, so that's essentially, then I would go down to the patellar tendon before I did the trochlear and look at the joint space, but come straight onto the patellar tendon, down, tibial tuberosity, scan again through, and you can, I don't know if you can make that out actually, just spotted something there. It's got a little bit of microcalcification here.
Don't give me bad news, Adrian.
A little bit of microcalcification within the tendon there. And just give a little bit of, just to see if that's upsetting the tendon anyway. Doesn't seem to be. Okay. Again, back to jumper's knee. Osgood slatters. Infrapatellar bursa. Superficial infrapatellar bursa. Then you need a good standoff for your prepatellar bursa, your suprapatellar bursa, here. Yeah, so those are all those bursts of the anterior part, and obviously coming down onto ITB, and you can assess the ITB there at Gertie's tubercle. So that, I think, covers most of the anterior knee. Just trying to think, I'll just have a look at me, see if I missed anything. Tendon of his knee, yeah. Yeah, covered all that. So let's have a look at the posterior knee.
While you're doing that, then, it's an interesting question. Would you not check the pes and anterior?
Yeah, well, I was gonna put the pes anterior as part of the medial in a couple of weeks, but
okay.
It does sort of go sort of posterior to sort of medial, anteromedial, and I'll probably cover that in a couple of weeks if that's okay.
Yeah.
Okay, see if you can see me there.
The suggestion was because of the hamstring, Adrian. Does that change the thinking? Or
What? Sorry.
A follow up to the question that came in just then is because of the hamstring. Does that change? Does that change the thinking?
Yeah, but I wouldn't routinely look at the hamstring for a knee thing unless they were worried about something that was connected, sort of hamstring. It doesn't hamstring usually comes as a thigh request, a posterior thigh request, or a hamstring request rather than a knee request. Where's my depth? There it is. Okay, so what we're looking for in the posterior knee is mainly Baker's cyst usually. Certainly, what I come across mostly is the Baker's cyst. You can look at the sort of posterior meniscus here, but as I say, you don't get to see much of the posterior meniscus or the medial lateral meniscus, but you can look at it. This is the cartilage here. This is a bit of the posterior meniscus. So what I'll do is I'll just show you how you get to the Baker's cyst. So you want to find now Baker's cyst always happen in the medial aspect of the knee. So you can get cysts on the lateral aspect, but they're not strictly Baker's cysts. They're different types of cysts, but the Baker's cyst tends to come to the medial aspect. And what you're looking for is, so you're looking for this big structure here, which is semimembranosis, and then the cherry on the top, if you like, which is semitendinosis. Okay, and then you follow that down until the membranosis comes into tendon. Okay, and then you get the medial head of gastrocnemius coming into shot here as well. So it's classed as a semimembranosis bursa, if you like, and it's between the medial head of gastroc, which is this sort of triangular point of the gastroc here, and the semimembranosis tendon here, and it comes up through that gap space, there. And I've got an image to show you of that in a bit as well. Okay. So that's where you routinely find it, and you need to look for a characteristic speech bubble. So the fluid will come out of here, and it'd be like a speech bubble coming out, and you need to make sure you see this speech bubble coming from the joint, because if you don't, then you need to worry about other things. You need to put Doppler on. You need to worry, look for and just make sure it's not like a sarcoma or something like that. So you have to be really careful with lumps and bumps and things within the knee and stuff. But just if you see that characteristic speech bubble and it's between the medial gastroc here and the semimembranosis tendon, you just brighten that tendon up there, then you're good to go. You can call it a Baker's cyst. Okay, so just go through that again. So this is semimembranosis, semitendinosis, and if I go any higher, you'll see semitendinosis come into semitendinosis muscle. Okay, for those interested in the hamstring, semitendinosis here, coming down, and if you follow the septi of the muscle, that'll lead into the tendon. Okay, so there's your semitendinosis tendon. That sits on top of the semimembranosis, which is here, and then you follow that down into the tendon of semimembranosis, and then medial gastroc, which is here. And then there's your place for your bursa. And then I just look around into the sort of medial joint space, look for any cysts or fusions. Look at the cartilage. I've got a bit of semimembranosis insertion here, so there's a bit of that tendon coming back around to insert here. So that's semimembranosis. And then I can come across and look at the lateral aspect, and again look at the joint. You're right, Abid, I'm not pressing too hard, am I?
No, perfect, thank you.
Gel. And you can see nice smooth contour here of the joint. Okay.
And when you're looking at Baker's cyst, do you ever look at gastrocs to rule out calf tears in the area?
Yeah, you can do. Yeah. And you just follow the gastrocs down.
What would a tear look like?
So for tears, I tend to get them into this sort of position here, where I'm looking for these fibrillar patterns in the muscle. Okay, so I know I've got the fibrillar pattern of the muscle in plane, and then I just look for any defects, and they'll be sort of dark, irregular defects. And muscle tears are quite difficult, so you have to sort of hone in on them and just scan them very, very gently through.
Do you need to be dorsiflexing and plantarflexing the foot to really rule it out, or can you just do that off a...
It all helps. So dynamically moving will move the muscle.
So I'm just dorsiflexing my foot there just so everyone can see the...
And you can see if there was a tear there, you might get a little bit of gapping with the tendon gap there. But look at the septi of the muscle. So those big thick lines in the muscle. Scan up and down and follow those, because those tend to be your best key into muscle tears.
Do you need to use the colour options to rule out? Are you looking for vascularity as well? If you suspect a tear, will there always be increased vascularity to it, or
there won't necessarily be much vascularity? You might see like a hematoma or something, which is just basically a bit of fluid and a bit of debris. But again, in the absence of trauma, and you see that, then you should be worried about other things. So always correlate with your clinical findings. If you see any of those sort of things with no history of trauma, you should just make sure to rule out other more sinister pathology. So you can see as I move up and down here, I'm just moving the probe up and down, and you can see how that muscle belly is just how its architecture moves all in one direction and the other. So you can get to see the plane, and the one underneath it is moving in a different plane. So here's the main septum, and you can see they move differently. So you can separate these two, and that's how you try and separate the muscles into the different components. So one thing, if they've got a big Baker's cyst and it's quite large, I will also tend to check the vessels just to make sure there's no sort of DVT or anything like that. And then you can put the colour on. Okay. And if I squeeze, I'm basically pressing Abid's lower calf here, basically just squeezing it, and you can see the blood pump up. Okay, so that's what I'm looking for, and then I'm making sure that the veins compress. That's an artery. But the veins, there you go. You can see I'm pressing those are the veins, so they're all compressible. So I would just check that the veins around the area are all compressing, and the Baker's cyst doesn't cause any sort of compression clot, anything like that.
How about the perineal nerve as it wraps around the fibular head? You know, you get these nerve entrapments there. Are you able to make anything out on ultrasound diagnostic?
Yeah. So this is. Oh, hold on a minute. Let me get the arrow pointing at the screen, and no one can see that. So here's the nerve here, and you'll see it split. And then this here will be the perineal. And you just follow that. Here's the fibular head. It'll wrap over the fibular head. I'm not going to lose it. Got no gel. So go back. Now, so, let's turn that down a bit, and then you can turn long section on that and just see if there's any change in the caliber, any focal fusiform thickening of the nerve.
Can you just highlight that? What you're looking at?
Yeah, let me just take this down a bit, maybe. So I deal with it now. Let's take that. Just adjusting things here. So there's the pepper pot appearance of the nerve there. So you can see the little fascicles within the nerve. If I go long section of that, so that's the nerve going there, and then so you're looking for any sort of fusiform swelling, fusiform swelling to that nerve. I've got a great image there. A bit better. That's a little bit better. So there is the nerve, and you can tell it's a nerve. You can see that sort of central black and white line going through the middle there. Yeah. Whereas a tendon will tend to have lots of little fibular components. So yeah, you can look at the nerve, and that will obviously go back. It is down here, back up into the sciatic. Yeah. And there it is in long section. But your requests will come, if they're suspecting neuropathy, they tend to come specific for that. Okay, let's have a look at, how do I flick over to my slides just to finish off there, Abid? That's pretty much the posterior aspect. I'll just go through some pathology slides just to sort of cover everything that we've done there.
Slide show ready for you just there.
So this is what we've basically just gone through. Now, can I get an arrow? I can't get an arrow on here, can I? So we've got obviously the patellar tendon, ITB that we went through, good, is tubercle there on the left-hand side, and the patellar tendon inserting onto the tibial tuberosity. And obviously onto the right side is the posterior aspect of the knee with the the gastroc muscles there, you can see, and what we've covered there. So these are the various bursa that we went through. So we went through the suprapatellar bursa. You can see that that's quite a big bursa, and that can extend over the medial and lateral aspects. Obviously, you only see it in one plane here. The prepatellar bursa, that's where you need to keep your probe very light with a good standoff gel.
Are you actually seeing, sorry Steve, are you actually seeing the PowerPoint on your my screen?
I got the knee bursa slide at the moment. Yeah.
Oh, right, okay.
Yeah.
Fine then, sorry, because I can see us on our screen.
I don't know, it's probably in there somewhere. There it is.
Yeah, right, okay. Sorry, my fault.
And then obviously your two deep infrapatellar bursae there on the patellar tendon. The pes anserine bursa, which we'll go through probably in a couple of weeks, because I put that really on the sort of medial aspect of it. And then obviously the Baker's cyst, which is your popliteal cyst that we did at the last thing on the posterior aspect between the medial headed gastroc and the semimembranosis tendon. And this tibial collateral ligament bursa, I've never seen that, but that's another bursa that you can get. So this is the infrapatellar bursa, and you can see the normal, what would look normal, and then what would look as abnormal. See that little black area just underneath the tendon there, on the tibia, overlying the tibia there. That's the deep infrapatellar bursa. This is that prepatellar bursa I was telling you about with that standoff. See how he's got a good standoff on the top there, that big black layer, and that allows you to see that prepatellar bursa that's just underneath. If you hadn't had that, you would miss that because it's so subtle. It's so subtle, and to squash that is so easy to do. So this is the trochlear that we looked at, and this is the various appearances of gout and CPPD. So with gout, you get this sort of deposition on the cartilage at the upper border of the cartilage, and with CPPD, you tend to get the little bits of deposition within the actual cartilage itself. So you can see how that's depicted on the left there, and the corresponding ultrasound image on the right. So that's one to look out for.
We actually had a question about the trochlear. On anterior knee, do you check the joint line?
Sorry, I missed that, Steve.
Sorry, on the anterior knee scan, would you check the joint line?
Check the joint line, yeah, absolutely.
Yeah.
Yeah. And then this is the Baker's cyst. So this is what I was talking about with the speech bubble. So you can see on the left-hand screen the way you've got the medial gastroc. It's sort of and the fluid sort of squeezing through the medial gastroc and the semimembranosis tendon, and it's that sort of speech bubble sign that you're looking for, and that'll help confirm that it's a Baker's cyst. And that's what it can look like in this longitudinal. So you measure it in 2 planes on the left, and then that one length plane on the right, and that give you like a 3-dimensional size of that bursa there. And finally, patellar tendinosis. So this is what patellar tendinosis looks like. You have a very hyperechoic tendon on the patella there, and in the top image, and obviously as you put the Doppler on, this is what it looks like with colour, and obviously what it looks like with power. So again, the difference between these two, colour is directional. So blue is away from the probe, red is towards the probe. So that's why you get differences in red and blue. That's the direction of the blood flow. So you can change the direction of blood flow by just angling your probe. We can go through that on the practical sessions because it's a bit more easy to demonstrate, but it's basically directional, whereas power Doppler is independent direction, it's just picking up blood flow. And I think that's my last slide. Yes, it is. So there we go. The knee, AP and the posterior.
Fabulous. Thanks, Adrian. Have we got any questions there, Steve?
I have got a couple, yeah. So if I can encourage everyone else to throw in any more questions they might have now.
Fire away.
So just an extension on that question I did ask a second or two ago. So on the anterior knee scan, would you check the joint line, the trochlear groove, looking for maltracking?
Have to do it dynamically, I suppose, then, wouldn't you?
Yeah.
But that's not easy to do. Well, you could have the knee flex hanging over the edge, and then extend.
Yeah. I mean, I guess they're talking about the patella, maltracking of the patella over the top. You can do that. You could do that dynamically, yeah.
Yes,
And
patella. Yeah, you can.
Yeah.
Yeah. So you do that dynamically.
Yes. Yeah. I'm not sure what you'd see on the actual the scan, but you can move the move the patella backwards and forwards for the maltracking and things like that.
Okay.
You can even look underneath the patella for arthritic areas by just sort of pushing the patella up and out. You did that the other day, didn't you, Abid, with doing the injection?
Yes.
And that gives you a good insight underneath, looking underneath the patella. But you can do that as well with the one I showed you on top of the knee, looking into the trochlea. You can just see the undersurface of the patella as well. So you can look for things like that.